For the We Free World blog, we are here with Professor Edward Shorter, a well-known Harvard historian of psychiatry who now teaches at the University of Toronto. We called him on the phone to talk on how and why psychiatry has switched its focus from mind to brain, and on how DSM is more a political document rather than a scientific one.
Historically, psychiatry was very oriented to psychotherapy. And in North America, Freud's doctrines were easily seen as the leading principles of psychiatric treatment. And 40 years ago, most psychiatrists outside of institutions did not really prescribe drugs. They gave psychotherapy. So the change has just been enormous. And there are a couple of reasons for the change. One has to do with the advent in the 1950s of drugs that were really effective in the relief of psychiatric illness. There have always been psychoactive drugs available, and earlier in the 20th century, the amphetamines and the barbiturates were introduced, and they were certainly important drug classes, but they didn't have a kind of central role in the discipline. Drugs started to become central in psychiatric treatment with the introduction in 1952 of the first of the antipsychotic medications. That was called Chlorpromazine, and that was introduced clinically in 1952. Chlorpromazine was an antipsychotic drug. It was effective in patients who had hallucinations and delusions and severe agitation. So this was a real eye-opener in 1952 when this was introduced, that you could give patients a drug like aspirin that would actually make them better, even if they had very severe illnesses. This was not really seen as possible in psychiatry before then. And the theoretical possibility of making patients better by giving them a pill didn't exist. People thought that if they didn't respond to psychotherapy, then you could put them in an asylum, and they would stay in the asylum until they got better, or they would stay there forever. And so this was a huge change for psychiatry. And it also stimulated interest in research on the brain as the source of psychiatric symptoms. In the older days of psychotherapy, the source of psychiatric symptoms was thought to be the mind. There's a sort of basic distinction between the mind and the brain. And in the days of the Freudians, mental disturbances were treated. Intrapsychic conflict was treated. However, the success of this drug all of a sudden shifted focus from the mind to the brain. And that's a kind of fundamental shift in psychiatry. Psychoanalysis started to go out of style. And I know that in Latin America it's different. Psychoanalysis is still very popular. But here it's not. Here psychoanalysis is really dying out. And so that was the beginning now of the pharmaceutical revolution, the arrival of drugs that were truly effective. Mania, depression, psychosis, anxiety, phobias, all within the period of 10 years of time became very treatable, and this was a major revolution. But then the next chapter in the story is that it turned out that the manufacture and selling of these drugs was so profitable that pharmaceutical companies started to make a lot of money from psychopharmaceuticals. And we're talking about billions of dollars here. The pharmaceutical industry started to become profitable on the scale of the oil industry. Lots and lots of money really was at stake. And so this naturally encouraged drug companies to try to persuade psychiatrists to prescribe as often as possible. And so how do you do that? How do you prescribe people? How do you persuade them to prescribe frequently? Well, you do so by selling them the idea that the major diagnoses in psychiatry are all diagnoses that respond to drugs. In the olden days of Freudian psychotherapy, the popular diagnoses were things like hysteria. Well, hysteria may or may not exist, but nobody ever talked about hysteria as responding to drugs. And so, well, what are we going to do about that? Well, we're going to get hysteria out of there. Hysteria was essentially dropped. And instead, the diagnoses that came in, particularly that came in 1980, in the third edition of DSM, and the interesting thing is that in the DSM, almost all the diagnoses are diagnoses that are drug responsive. Indeed, that many companies have spent a lot of money developing, such as social anxiety disorder or major depression. These are diagnoses that have basically been marketed by the pharmaceutical industry in the way that they market drugs. But in this case, they aren't marketing drugs, they're marketing diagnoses. And so all of these drug-oriented diagnoses are being sold to psychiatry as though they corresponded to natural disease entities. And this is the problem, that the major diagnoses of psychiatry today are diagnoses that suit the convenience of the pharmaceutical industry. And so psychiatrists, when they see patients who come in with a mixed collection of symptoms, but psychiatrists see patients today, but what they see is not really a patient. They see a diagnosis, and the diagnosis that they see is usually a diagnosis that has been marketed by the pharmaceutical industry. And so this is the basic reason why psychiatry today has been overwhelmed by drugs.
But why the interest of the pharmaceutical companies matched so well with the interest of the psychiatry community in a way?
You don't get a direct payment from the industry for prescribing, but industry has various ways of giving psychiatrists payments nonetheless. Mm-hmm. They can put them on their panel of speakers, so that a given drug company might have hundreds of psychiatrists on its speakers panels, distinguished psychiatrists who are willing to go around and give lectures to their colleagues in the community on behalf of the industry, and for each lecture they might receive $2,000. Well, if you go around and give 20 lectures on behalf of a drug company and its drug, very soon you will start to be a wealthy man. And psychiatry used to be at the bottom of the medical incomes, and there are still many psychiatrists today who don't make a lot of money. But the leaders, many of the leaders in psychopharmacology whose voice is seen as authoritative and whose judgments attract national attention, many of these men and women have become wealthy. The interests of the two overlap now almost 100%. Yeah. The industry is important in financing trials for various diagnoses or indications, as they're called, and the indications that are being funded for hundreds of millions of dollars by the pharmaceutical industry are all indications for which the pharmaceutical industry has drugs. And so it's like the glove that fits the hand. The hand is the psychiatrists who are ready to prescribe and only need diagnoses in order to justify the prescriptions. And the glove is the pharmaceutical industry that supplies the medicinal agents and supplies the diagnoses that go with the employment of these agents. And so something like the SSRI class of drugs, the Prozac and Zoloft style drugs, are indicated for major depression. Well, you say, well, what's the matter with that? If major depression is a real disease and they have drugs that cure major depression, what's the problem here? The problem is that some of these diagnostic entities that are marketed by industry are diagnoses that don't really exist in reality. In reality, there is no such thing as major depression. The term is a very, very heterogeneous mixture of different kinds of patient populations, a mixture of patients with different kinds of mood disorders. Some of the mood disorders are responsive to drugs, some of them are not. And so they all get lumped together under the term major depression. And clinicians who believe in major depression believe that the SSRI drug class will cure major depression.
Yeah.
But it won't, because there are lots of people in this major depression pool who don't respond to Prozac-style drugs. So that's the problem.
People like you who really talk about these issues openly, like, did you ever have any problem with the pharmaceutical industry?
The industry would never do that. But what they do in order to get people on side is to make them advisors or to make them members of their speakers' bureaus. And then there's a lot of money that flows from industry to these advisors. And the men and women who become advisors are all people who are very sympathetic to the diagnoses that industry favors. And I've never been an advisor to anybody. The industry's never subsidized my attendance at any conferences, or they've never given me favors of any kind, simply because I have never been useful for them. There's nothing that I have to say would be seen as helpful to the pharmaceutical industry.
So basically, from what you said, the DSM pretends to be very scientific, but is not.
It's not really that scientific. We tend to think of psychiatry as part of medicine, and as medicine as having a scientific basis. But the classification of psychiatric diagnoses is a little bit different, because here the principle of consensus is the guiding principle. Now, in something like physics, we don't decide things by consensus. We don't decide the speed of light by consensus. We don't have one person who says, well, I think the speed of light is X, and another person says, well, I think the speed of light is Y, so they get together at a conference and average them all out. That's not the way we do science. But the way illness classification is done in psychiatry is on the basis of consensus. People get together around a table and basically do horse trading. They trade diagnoses, or I will give you this if you give me that, basically on that principle. And so the DSM becomes a political document. It doesn't become a scientific document. And this kind of consensus politics was probably necessary at one point in psychiatry, because the discipline of psychiatry was split so badly between the psychoanalysts and the biologically oriented psychiatry. In order for there to be a single professional organization that would produce a single diagnostic classification, there had to be some horse trading, even though the horse trading was unscientific. But we're way past that now, and still the principle of consensus is the principle that guides the drafters of the forthcoming DSM-5. And here again, the principle of horse trading rather than science prevails.
So what made the DSM become so successful?
Well, the DSM became successful in the way that American medicine everywhere became successful, in that American medicine is now the sort of international guideline for medical research. What happens in the United States is seen as pathfinding, and the rest of the world follows. This is because after the Second World War, Congress gave hundreds of millions of dollars to the National Institutes of Health for medical research, and no other country was able to match this enormous influx of funds. And so American medical research before the Second World War was really very much behind European research, but Europe was dealt a heavy blow with the Holocaust in the Second World War. In Latin America, the German tradition in psychiatry is still very strong, but nowhere else is the German tradition in psychiatry strong. And before the Second World War, Germany was the leading country. Well, after the war, America took the baton from Germany, and this happened in psychiatry just as it happened in cardiovascular surgery. So it's not a surprise that American psychiatry would become sort of a world leader, because this happened all across the board in medicine. But what is unfortunate is that DSM, which is a basically unscientific document, has had such an enormous impact.
So talking about the DSM-5, all these diseases like psychosis, risk syndrome, mixed anxiety, hoarding, I mean, all these kind of things that they will enter?
Well, need to be fundamental changes. For example, for about 100 years, there's been a firewall between psychosis and mood disorders, depressive disorders. They've been seen as really very different categories of illness entirely. But that's not true. In the world of nature, many patients with mood disorders are psychotic. There's a lot of overlap in terms of genetics and responsiveness to drugs and responsive between mood disorders and psychosis. However, that firewall is going to stay there. So that's one problem. Another problem is the diagnosis of bipolar disorder that has become enormously popular. And yet, there is really no such thing as bipolar disorder. You have patients with depression who may or may not have an attack of mania, or hypomania. And if they have an attack of mania, does that fundamentally change the diagnosis and mean that they now have bipolar disorder rather than depression? No, it doesn't change it at all. It's ridiculous. So this artifactual diagnosis called bipolar disorder has been permitted to get all out of hand. Major depression is going to stay in as a diagnosis. There's something called dysthymia that is going to stay in, that is really just a chronic version of major depression. All of these really are not natural disease entities. If we were operating in a strictly scientific way, none of them would be in. Schizophrenia, there is no such thing as a single disease called schizophrenia. Rather, there are different kinds of chronic psychoses that are really quite different, and it's a mistake to lump them all together in the term schizophrenia. So these are all diseases that are in the forthcoming DSM that should not be in there. And another thing about DSM-5 is that for the first time, an officer of the APA is actually in charge of it, is a co-chair with an academic. And so the APA has very firm control over the drafting of DSM-5, and they are going to try to make sure that there are not major discontinuities of previous versions. But what is needed is major discontinuities. That's the point.